So hello and welcome everyone to the second webinar in our Australian FASD Guidelines webinar series. I'm Viv Lyle and I'm the project manager for our Australian FASD Guidelines dissemination project. And we join you in this webinar from Meanjin in Brisbane on Yagara and Turrbal country in Queensland. Before I get started, I really want to take a moment to pay my respects to the elders who are here, those who have come before us, and those who are emerging on this country. And I also really want to acknowledge the First Nations people who invaluably contributed to the development of our new Australian FASD guidelines and also our Indigenous FASD framework. So in this session, you'll hear from Associate Professor Erin Olson, who's a clinical psychologist from the University of Washington. And Erin brings an absolute wealth of knowledge with over 15 years experience in neurodevelopmental diagnostics, and particularly with FASD and autism. And Erin in this webinar presents findings and clinical insights from her work at the Washington FASD Diagnostic Clinic, where assessments are completed using the US 4-digit diagnostic code. And she reflects on some of the important nuances and considerations when undertaking assessments that practitioners really need to understand when considering both FASD and autism. And as you watch, really encourage you to be aware that there's some important differences between the 4-digit diagnostic code that's used in the States compared to our current Australian FASD guidelines for assessment and diagnosis. And these relate both to diagnostic criteria and also in some of the important terminology. So for those viewing in Australia, we really encourage you to refer to our current guidelines, and you'll see a QR code on the screen for that that'll take you directly to them so you can download them and get some further information on them. And finally, for everyone, we really hope that this session offers an opportunity to reflect on international practice and how to consider different diagnostic models to inform our shared work. So thank you so much, everyone, for joining us.
Great. And is everyone seeing my slide? I'm looking on yours. I'm imagining that you can. The title
Yes.
slide. Great.
We can see you.
Okay. Great. Thanks for the introduction, and thanks for putting this this talk together. I'm going to dive right in. I too had a land acknowledgement recognizing the Indigenous peoples of Australia, and also wanted to add that the work that I do is on the unceded ancestral lands of the Coast Salish peoples. So I too honor the land and the shared waters that these lands touch and pay respect to the elders past and present. So before we get started, I just wanted to make sure that that we acknowledge where we're at and the work that we do and the places that we're at. I do have some disclosures and disclaimers, but the disclosure I have is not financial. I don't have any financial conflicts of interest for this presentation. And I wanted to share that my training and expertise is broadly in neurodevelopmental and behavioral areas, primarily in autism and FASDs. I wear a couple different hats in Seattle at the University of Washington. I'm at the UW Fetal Alcohol Syndrome Diagnostic and Prevention Network clinic, which is a interdisciplinary medical diagnostic clinic. And the data that I'm looking at now will be data from that clinic, which has been around for 40 years. I'm also at Seattle Children's Autism Center, where I'm the training director. And I'm also an attending psychologist in our SNACS program, which does kind of a single discipline, a lead psychology diagnostic approach, and is a training center as well. So we use more of the DSM-5 criteria there. That in and of itself, those two different kinds of approaches for diagnosis, is something that we find a lot in the field of FASDs. And so we'll talk a little bit about that, but not quite a lot, because I'll spend most of my time talking about using the 4-digit code for FASDs and DSM-5 for ASDs. The field of FASD is, as those of us who work in this field know, it's ingrained in conflict. There's bias, there's stigma, there's still inequity, and we're all real working through that. So I just wanted to make sure that we lay that out on the table. And if there are questions about that or anything we want to discuss, I think that's important. There's not a lot of consensus about diagnostics. There's differences, opinions in the field of diagnostics and autism too. So we'll talk a little bit about that. But there's lots of difficult discussions that are to be had, and the more that we can have these discussions, I think we can come up with eventually some sort of consensus, or at least some ideas or pathways and approaches that can help us better understand how to support people who have differing needs. Some of the slides and the images were prepared by Dr. Susan Astley Hemingway, who's the director of the UW FASDPN clinic, and she is in charge of all of our data and has a wealth of knowledge and has created quite a rich database from all of our patients that we've seen over the years. And also Dr. Heather Carmichael Olson, who is the creator of Families Moving Forward program. She actually is the one who kind of brought me into the fold in the world of FASD, doing some research in my pre-doctoral years, and the Families Moving Forward program, which is a parent behavior management program for caregivers of youth with FASDs. It's one of the few there are evidence-based programs, but this one is pretty robust and widely used. So look it up if you aren't familiar with it. And there's trainings offered. We recently trained someone in Tasmania, and he came at 5 a.m. to the meetings, but was quite a trooper for us. And so I thank Heather for bringing me into the fold, and then also she was the one who introduced me to the UW clinic as well. So I definitely thank them for their support. Today, I wanted to talk a little bit about the diagnostic features of ASD and FASD, just to get the lay of the land, and then talk about the current state of the research regarding differentiation of both ASD and FASDs, thinking about the trends in the symptoms from our data, and understand the need for the needed future directions. One of the things that I will have to say is I really did think that today's chat was going to be more intimate, like it is in the room. Dr. Natasha Reed invited me to come out here, and she has a Cracker Jack team who apparently made it so that it's widely available to many of you, and I'm thrilled to see that there's so much interest in this topic. I will say that this data is not for the whole span of the 40-year data that we have. We're just starting to dig into this. I'm not the only one that's interested in this differential. It is obviously a hot topic. So I was chatting with my partner, my husband, who's here today too, and he's like, just let everybody know this is like the teaser before the summer blockbuster comes out, right? So we're going to talk a little bit about some very preliminary data and some trends that we're seeing, and hopefully by the time we get to the international conference within the next year or 2 years, we'll have a lot more data to look into from our 40 years of work. We have other people that are looking into this as well. We did a presentation at the international conference in Seattle last year, collaborating with the Seattle Children's Autism Center and the University of Rochester, who are also looking into this. So Julianne Myers and the team over there is doing this similar work. So it'll be very interesting to compare notes. But there's not a whole lot of data out there, and so there are people doing it, but we definitely need more people diving into thinking about what differentiates autism and FASD, and what do they look like when they are comorbid, because they're certainly not mutually exclusive. Just very quickly, let's dive into the diagnostic criteria. We typically use the DSM-5 diagnostic criteria for ASD. You can also use the ICD-11. We're still using the 10 in the US. I just read an opinion article by Camp Becker, I think, and really talked about how this is an alternative approach, but the criteria through ICD is pretty vague, and so we get a lot of false positives. It's not very specific. So we all tend to use the DSM-5 criteria. Um, so we're looking at social communication differences and differences in social emotional reciprocity, nonverbal communication, developing and maintaining and understanding relationships. And for very young children, that can look like, how do you play, and are you playing in the stages that you're supposed to play in parallel to social cooperative type plays? And are you able to engage in imaginative play? So you have to have deficits in or challenges in all three of those areas to meet criteria for an autism spectrum disorder, in addition to repetitive and restricted patterns of behaviors. So stereotyped or repetitive movements, insistence on sameness or being inflexible, somewhat rigid, highly fixated or restricted interests that are highly intensive, or sensory processing differences. This is a change from the DSM-4. So in 2013, the criteria changed, and now you only need to have 2 of these 4 RRBs, you can call them. And we're seeing some trends that maybe might differentiate ASD and FASD in this section, whereas you can meet diagnosis on paper, like by checking this off. It may not necessarily feel, I guess, for lack of a better word, like autism, that the way we've learned about and know about what autism is. So we'll talk a little bit more about that. The other main criteria are, it has to happen in the early developmental period. So typically we think about before the age of 3, and then cause clinically significant impairment, because why would we provide a diagnosis if the person didn't need support? And then there's some rule outs here that we need to think about, if it's better explained by some other diagnoses. And then we specify whether or not there's intellectual or language impairment associated with it, what level of support the individual needs, and then if it's associated with genetic, medical, or other environmental conditions. All right, so we know about that. I do want to think about these ASD diagnostic considerations, though, particularly because we want to be inclusive and understanding. And most autistic individuals and allies identify that this is a variation of the human condition, right? This is one of the reasons that it is a spectrum, and the human condition is a spectrum, and support the perspective of neurodiversity rather than autism being a disorder or a disease. The disorder comes in when it's causing functional impairment, and that's where we're labeling it and trying to help identify some sort of approaches to intervention or accommodations that can help people be successful in different settings and situations. And the diagnostic criteria has been based on, the current research evidence that describes the cluster of symptoms that we're seeing, that vary from what, and I put this in quotes, what we think of as typical development, broadly typical development. And like I mentioned, it causes some sort of impairment. Otherwise, we would not be giving a diagnosis. I already mentioned that we want to inform intervention and accommodations. And most autistic individuals will report that environments are just not inclusive to them. It's not built to support them. And, it's similar to thinking about, being in the deaf population. It's a hearing world. It's not necessarily built to support a deaf population. I even think of, being left-handed, right? That's many things are made for right-handed folks. So just thinking about how the environment can support individuals to make it so there's not as much functional impairment is a really important perspective and approach. Autism is multifactorial. That's another difference between FASD, which we know FAS anyways has a single cause. ASD has potential causes, and the research is leaning towards having a genetic predisposition with some sort of environmental impact or other impact, but no single cause has been identified. There's several genes that are implicated. There might be many genes implicated, and a lot of times we talk about it as autisms rather than just an autism. And like I mentioned, FAS is caused by prenatal alcohol exposure, so we know that there's a causal factor there. It gets more complicated when we talk about FAS or FASD as a spectrum because then we lose some of that causal factor. We'll talk about that in just a second, though. But one of the things I was thinking of when I was thinking about the autism realm being that there's conflict or disagreement with the diagnosis, particularly in 2013. Actually, before that, in the task force that were making the diagnostic changes, there was definitely disagreement in the changes. So there still is some disagreement around autism diagnostics, even though I think broadly we're all using these criteria. Particularly, I'm thinking of prominent researchers who left the task force because of the omission of Asperger's, which people very strongly felt was a separate diagnosis and kind of needed its own category. It still exists in the ICD 10 and 11, so it is a diagnosis that can be used, but typically people are sticking with autism spectrum disorder diagnosis. All right. Now, FASD diagnostic approaches, there's so many different guidelines. I know you all helped support the Australia guidelines, which just came out fairly recently, right? This past year. So that's exciting and new. Canada has guidelines. There's different guidelines out in Europe. There's also the DSM-5 guidelines, but that is in the section for conditions for further study, which means that it's not an officially recognized diagnosis, but is recognized as something that needs to be addressed and discussed further. The interesting workaround for that is that whoever was on the task force for other specified neurodevelopmental disorders, if anyone has looked in that section, the other specified neurodevelopmental disorder example, and I don't know if you can see, it's very tiny in the writing. The example there was neurodevelopmental disorder associated with prenatal alcohol exposure. So that seems like an interesting accident, but it does give us a diagnostic code that we can use, and we at the Autism Center at the Snacks Clinic use the NDPAE, but the neurobehavioral disorder associated with prenatal alcohol exposure criteria, which is out here outlined in the little web here, talking about the different kinds of areas that we would see impact and what we would expect in those areas, and also has to have kind of a threshold of alcohol exposure, because what is omitted from this is actually doing some of the more medical approaches of the facial features, really examining growth and other things that prenatal alcohol exposure can cause. And so we want to make sure that the alcohol exposure was to a sufficient degree that it could potentially be a causal agent. So it's kind of the way you work around it when you're trying to do a single discipline diagnosis. So we do that there. It's an interesting line to walk. There's pros and cons of using this approach. It can be much more accessible to a lot of people when you can get in and see one practitioner rather than having a group of people, an interdisciplinary team. The interdisciplinary team, on the other hand, enables us to look at those other medical pieces and rule out different factors that could be associated with these diagnoses, which we're going to talk about because I do have some interesting factors in the group that I'm looking at. So we're using the 4-digit code at the FASDPN, and the sample that I've taken is from this clinic, so they all have a 4-digit code. We look at growth, the 3 facial features, which I'll show in a second, although I'm sure many of you are familiar with those. We look at brain structure and brain function. We also look at prenatal alcohol exposure. However, we basically just need someone to confirm that there was alcohol exposure, a reliable reporter, and they gain access to our clinic. We don't have to think about thresholds. But because of that can make it more complex to diagnose whether or not alcohol was a causal factor. And actually, at that point, if we don't have facial features, which we know are specific to alcohol exposure, then we're thinking more of alcohol exposure as a correlative factor, right? Something that is in the mix with all of the other factors. Even if we have a full FAS diagnosis, though, it's still in the mix with all of those factors, right? So we just don't know how much we can pin on the alcohol exposures causing some of the challenges that an individual might be experiencing. We also think about other prenatal risks and other postnatal factors that can influence those diagnoses, other exposures to other teratogens, other, polysubstance exposures, um, maybe maternal stress, postnatal risks can be birth trauma to experiences of abuse. We have a lot of families or children who are in the foster system or out of home placements. So those risks can also help explain some of the challenges children can be experiencing. For example, emotion regulation challenges or anxiety, those types of things, traumatic stress. That can be an explanation. So we want to make sure we're thinking about those as we're doing this whole diagnostic code. So even though it's called the 4-digit code, there's 2 extra just to make sure that we're doing our due diligence. The diagnostic code was updated this past year. Dr. Hemingway has published that, and one of the big differences that we have, or that she has done, is she's removed the category of partial fetal alcohol syndrome. That was so problematic for many, many reasons. One of the reasons was people thought you had a touch of FAS rather than what it was really trying to say. And partial was meant that you didn't have all of the factors, like the full growth, for example. But people interpreted that quite differently. And what she found in the research when she went back and reviewed all the data is that the impairment and the kind of interventions that people were recommending were the same for PFAS and FAS. So now those are collapsed into FAS. We still use that static encephalopathy under the FASD umbrella to indicate more severe functional impairment when we don't have growth or facial features. And then we use, instead of neurobehavioral disorder, alcohol exposed, we use neurodevelopmental disorder associated with alcohol exposure. And those tend to be on the more moderate to mild impacts. However, we think that it's a really important diagnosis to keep under our umbrella, because even though it can be milder, meaning it doesn't have, the individual doesn't have 3 areas of brain functioning that are below 2 standard deviations from the mean, from what we would expect, they could have a whole bunch of 1.5 standard deviations below the mean. So there could be many, many areas that are impacted. And a lot of times, just like the name in the original name, the neurobehavioral disorder indicated, is that the behaviors that we're seeing are often more can'ts versus won'ts, for example, right? And we're interpreting them as intentional. We wanted to make sure that people understood that those challenges were very likely brain-based, and that we needed to come up with other ideas and other supports for individuals rather than thinking of them as the naughty kid, right? Here are the facial features that I was just talking about, the 3 facial features. We look at the palpebral fissure length, which is, I wonder, there it is, which is the endocanthion to the exocanthion. So it's the width of the opening of the eye, and that's plotted on growth grids. We use software developed by Dr. Hemingway to measure that. We have these lip and philtrum guides. So you can see here this very thick upper lip and a deep groove here. That is on the other end of the spectrum. Typically we'd have 3s and 2s is what we would be seeing. And in the FASD ranges 4 and 5 here, where you can see very smooth philtrum and a thin upper lip. And we do lip circularity using the software as well to determine where it falls on this. And we really use the guide to determine the kind of depth or the smoothness of the philtrum. There has just been a new Microsoft Windows update that has somewhat crashed our facial analysis software, which is really unfortunate. So if you have the facial analysis software, don't upgrade if you can. Hold off a little bit. Dr. Hemingway is working with someone to upgrade the software so it will work with the new upgrades. But that does happen, sadly. And there's really fascinating work being done on 3D imaging, and other ways of imaging faces and measuring eyes, and anything from software apps on your phone, to really complicated 3D morph. I can't remember exactly what it's called. But those are in progress, and those are in the works. There's been some really interesting work done with those, and so I'm pretty excited to see how those will come along, and help be more accessible to people as well. But anyway, so these are our faces, just some examples of what the face of FASD might look like in different races. And you can see it's a very cute look, right? Oftentimes we see smaller head sizes, so even though we're talking about much smaller eyes, 2 standard deviations below what we would expect, they still oftentimes look quite big. And no one out there who doesn't study this would probably recognize the face of FASD. But we always kind of joke as a team, it's like, now we can't stop looking at people's faces and the filtrums. And in fact, I even complimented Freddie's filtrum the other day. I was like, look at that very well developed filtrum. To which she replied, and his very large head size. Yeah, so those are the facial features that we look at. And then just quickly, so we do have some big data from our sample, looking at 1,100 subjects, 8 and older, and we selected, and Dr. Hemingway selected that age range because we were able to measure executive functions and memory, more things that we can't necessarily do with younger children. And we were really wanting to think about what is the function of the population, and can we start thinking about these developmental profiles? And yes, we can, and still it's a simplification at this point. We're still digging into it. One of the things that she has published recently is that even though we're looking at 3 domains of brain functioning that are 2 standard deviations below the mean, many of the people that we see actually have quite a number of them, as you can see, not just 1 domain, but some have all the way up to 9. So 48% of our subjects presented with severe dysfunction in 3 to 9 of the functional domains. And those domains are listed, where's my little thing? Oh, it's really big. Is, cognition, so IQ, thinking and reasoning, academic achievement, adaptive functioning, so independent daily living skills. We here in our data set right now have executive function and memory collapsed. We're working to separate those out because we're hearing from quite a few adults with FASD that memory is quite a large impact to their daily functioning. What I'm finding anecdotally is it's hard to necessarily measure that. Memory is impacted by attention, all sorts of different things, but also in a perfect setting where it's quiet and it's one-on-one, we can, and if it's an interesting, engaging task, we can get scores that show memory is fairly intact. But when you get out into the real world where there's noises and distractions and all sorts of things going on, there's other impacts that might be impacting the day-to-day memory of individuals that we're not able to capture in a lab or clinic type setting. Also, motor and sensory are collapsed together. We know that quite a lot, if not almost all of our children that we see or youth that we see have sensory processing differences. And also we see quite a lot of motor and fine motor differences as well. So that's another area we'd like to separate out and become a little bit more nuanced in looking. Same thing with language. Language is expressive. Language can be receptive. Language can be social communication. So there's that's just so much more complex. And it would be an interesting area for a speech language pathologist who might want to come and look at our database to look into. Many of our kids have ADHD, as our youth have ADHD as well. Behavior and emotion regulation is one of the top reasons that they come in. And then we also have measures of development, so birth to 3 measures. So we look at historical data as well. So even though these are 8 and older, we may have birth records and, Bailey's or Batel's, more developmental, broadly developmental measures. This other graph over here is showing the number of diagnoses in these kids, or in these youth. So 9% of these, so 98 of those 1,100 had full FAS or partial FAS, because that was still what we were using then, which is pretty typical. Kind of 1 in 10 of our kids, our patients have FAS. Otherwise, a good chunk of them have static encephalopathy, alcohol exposed. And remember, that's where they still have the 3 domains of impact, at least 2 standard deviations below the mean, but not the facial features. And then 50% had the neurodevelopmental or neurobehavioral disorder associated with alcohol exposure. So this is a big, broad group of individuals that come to our clinic, and we very rarely have anybody come to our clinic that isn't exhibiting some sort of challenge. Once in a while, we'll get infants in who we know have been exposed, and so that's kind of a rare exception. But otherwise, they come to our clinic because there's some question about functioning, and so there's something going on that the families need and the caregivers need help with, and so we see that that's a valuable diagnosis for families. These are the developmental kind of patterns that we're seeing in terms of these diagnoses. And so red here, if it's translating well on your screen, is FAS and PFAS. And then I'm not even sure, orange, I suppose, is the static encephalopathy, and yellow's the neurodevelopmental disorder. And you can see here that the trends sort of follow one another. The severity is maybe less, as we would expect, the way the diagnosis is arranged, but we're also seeing that there's very high levels of executive function difficulties in both static encephalopathy and full FAS. Quite a lot of language impairment as well. Adaptive functioning tends to hold. You can see here behavior is still the number 1 under ND, AE, and lots of our individuals have comorbid diagnoses of ADHD. I was talking to some Scandinavian colleagues who visited our clinic, and typically when the child has ADHD, they don't also code executive function as a challenge, because oftentimes we consider ADHD and executive function as going hand in hand. So again, there's some differing opinions. I differ in that opinion because while I look at ADHD as having inherent impulsivity, so inhibition challenges, organization and planning challenges, there are other areas of executive function that you can measure separately that some people with ADHD don't necessarily exhibit. And for example, cognitive flexibility is one area I typically will want to look at. Working memory can go hand in hand with ADHD, but also can be separate. So we look at broadly executive function in addition. And so if we're coding ADHD and executive function, we typically don't say if it's impulsivity and ADHD. I wouldn't call that a double hit, for example. I would call that ADHD and then be looking for maybe a different area of executive function to see if that's an appropriate one of the 3 diagnostic criteria. So that's our sample right now, at least part of our sample, our 8 years and older. I'm going to move up here and think about what is the current research in autism and FASD. And like I mentioned at the very beginning, there's few publications. I think when we did our last lit review, we found less than 100 publications looking at both ASD and FASD, and from very different approaches. They focus on different things, quite variable sample sizes, um, and then lots and lots of challenges regarding retrospective reporting, underreporting. A lot of people are promoting use of questionnaires for pregnant people. What we're finding is that is an even larger underreporting. Putting it in writing seems to be even more daunting than saying and reporting it, because there's still stigma around drinking during pregnancy, or even just drinking in general. So people do tend to underreport. And then being retrospective too, you may forget. You don't necessarily remember or know the timings or the doses or what you were drinking at any given time. So it also makes it difficult to think about the impact of when you're drinking during pregnancy, or how much you're drinking during pregnancy, and what impact that might have on the developing fetus. There are a bunch of large studies between 2003, I was going to say 2003, 2003 and 2017. Some very large ones. There's some from, I'm going to forget where it was from, but Eliason looked at I think over 18,000 individuals in their population. And basically, a lot of the findings were that there was no association between maternal drinking during pregnancy and autism, specifically, that they could find. There were some unusual findings. Like one was, this is very specific, is one binge drinking episode early in pregnancy, in pregnancies that were easy, like within 6 months of trying. It was associated with lower risk of autism. I don't know how to interpret that, but also interesting. And then Carpita out of Italy did a lit review, and based on a lot of the things that they were reading, so somewhat hypothesized that less drinking in difficult pregnancies tended to happen, or those parents with children who already had medical or developmental challenges drank less during pregnancy. So they were seeing more like healthier individuals, or people with healthier pregnancies, drinking even more into like the third trimester, which seems unusual, but perhaps didn't have that on their radar, that you know that this could be impacting a child's development, whereas a person with a difficult pregnancy or a child who already has developmental challenges would probably be trying to abstain from anything that might have some sort of impact, right? Also, there was highly variable prevalence of ASD and FASD populations, ranging from 2.6% to 68% in the populations that they were looking at. And again, it was such variable sample sizes. And I think when one of our trainees last year was looking at this, found something in like 1.4% up to 70 some percent. But it's just wildly variable in how many individuals in an FASD population are also diagnosed with an autism spectrum disorder. And those citations are just two of those studies. I think there's at least four or five. And then here out of Perth, there was a really interesting study done in 2020 using that 3D facial analysis software, and they did not find any association with alcohol-related facial features and the behavioral or cognitive features of autism. So I think really is what that's showing us, is that there's separation here. These are two different things, and I think it really helps us consider that they can happen separately and they can co-occur. One doesn't cause necessarily the other, but maybe it does, right? Like, so if we start thinking about genetics and other factors, and if we're thinking about autism as having a genetic predisposition, And if prenatal alcohol exposure is an environmental condition, could that potentially impact? That's a big question that I think that we need to address in our research moving forward. This is a slide developed by one of our trainees, Lauren Perovsik, who co-presented and actually led the presentation at the international conference last year. And it's just a really, it's a lovely visual way to kind of think of the overlap and the variation in some of the symptoms or the impacts that you might see with either of these diagnoses. So as you can see here, we have everything from facial features and growth to cognitive, self-regulation, all the way down to restricted and repetitive behaviors. Oh, oops, come on. I'm hoping that it's going to show there we go, animation. I don't have a lot of animations because a lot of times they don't work. But what we'll see, so that broad umbrella there are the impacts that we will often see with FASD. And then those are the ones that are often associated with autism. And so you can see there's quite an overlap. And I would even posit that there's more of an overlap where we can see, hold on here. Lots of difficulty with social interactions, but a desire for social interaction in FASD. Autism can also have intellectual disabilities or executive function challenges, self-regulation challenges that overlap. Oops, I'm looking at my arrow on the wrong screen here, such as at FASD, but these are more central oftentimes to FASD, whereas conversely, FASD can have these language challenges. Definitely, I would say sensory is a big part here. I might even make this even darker. And one of the big areas of difference that we're seeing is this restricted interests and repetitive behaviors. One of the things that we see is kids with FASD or youth with FASD, individuals with FASD might be talking a lot about something that they're very interested in and not really recognize the need to take turns, right? We often call it kind of logorrhea, where it's just like, you're just letting it all out and talking all about all the things that we want to talk about because we're excited and we're interested in it. But there's still that level of, I want to share this information with you rather than this is the only thing I want to talk about, right? Which is a bit different from the way we think about restricted interests in autism. Like, it's very hard to pull them away or change the subject from something that's one of their true specific interests. And then the idea of repetitive behaviors, the spinning objects, the repetitive language, the fascination with parts of objects, things like that, are not typically seen in FASD unless it's also an FASD and ASD. So those are kind of some of the differentials that we're looking at. Affect sharing, nonverbal communication is often more of a difficulty with individuals with autism or autistic individuals, whereas individuals with FASD may not be interpreting those cues appropriately, or they may not be catching on to them, they might not be paying attention to them. So there's an idea of thinking about, okay, this is a potential challenge. So instead of saying, is it a challenge, it's like, well, why is it a challenge? Like, what is the underlying reasoning behind these? Is subtly different for many of them. So the social interaction challenges often that we see in FASD is not that they're not aware, it's not that they're not desiring or motivated socially, it's that they don't do it quite well, right? Or they're too impulsive, or they're too unpredictable for the play partner. So they have problems with peers. Whereas oftentimes what we might see on the autism side of things is that it's more of a not necessarily a lack of interest, because that's not an accurate way to portray autism, but it's less need or less motivation to have as much social interaction, I would say, as kids or individuals with FASD or other neurodevelopmental differences, or people in general. being herd animals that we are. Let's see. Oh, now I'm gonna go. Okay. So I might have moved this in, oh, nope, I didn't. These are the symptoms that overlap and some of the differences that we're seeing in the literature. Commonalities, like I was just talking about, difficulties with social interaction, executive function challenges. Externalizing behaviors often happen in with both diagnoses, especially in younger individuals. A lot of times externalizing behaviors can be looked at quite differently depending on the diagnosis. However, both I would say really stem from brain-based differences, where we might be overstimulated by the environment, the expectations might be a mismatch, and we're behaving in a way that communicates that this is too much for me and I cannot do it, or I need help, or I need support, and I don't exactly know how to ask for that appropriately. Theory of mind deficits has been shown to be across the board. So understanding what you're thinking about and what your motivation is can be challenging for both sets of folks. Manual dexterity challenges, we talked a bit about fine motor challenges. So we do see that in both ASD and FASD. Sleep difficulties are quite prevalent. Gastrointestinal challenges are prevalent as well. There's a lot of look into the microbiome in fetal alcohol syndrome and fetal alcohol spectrum disorders. And there's been a long history of look into different diets and things like that to help with GI issues in autism as well. Definitely sensory processing differences. The idea of being rigid and inflexible often comes up, and those restricted interests. And so if you can think about those diagnostic criteria for autism, if we can look at this and think about, okay, if I have FASD and I'm also thinking, does this individual have autism as well? I'm looking at those social interactions areas. Am I able to interpret other people's nonverbals? Do I use nonverbals? Can I make friends, sustain friendships, understand other people, and understand those kind of relationships? Am I reciprocal? Do I take turns in conversations? You can see very easily that both ASD and FASD can meet that criteria under social communication. When it comes to the restricted and repetitive behaviors, however, we might have restricted interests that come out looking like this is all I want to talk about. Or we might really have highly fixated interests, very strong interests that are hard to get onto other topics. So that might be a subtle difference, but it's still restricted interests. We'll see sensory processing differences, and we'll see rigidity. So they can get at least 2 or 3 out of those 4 criteria without having perhaps repetitive behaviors. And so that you can see on the other side here is we're seeing more in the autism population and autistic youth, as well as diminished use of nonverbal communication rather than not just understanding nonverbal communication. Difficulty sharing affect, the initiating interactions often seen in ASD, whereas with FASD we see poor social judgment. We see a lot of these youth being taken advantage of because of their social motivation and desire, but not really being able to read the room or not really being able to understand or think consequentially. So that can get them into trouble at times. So they need a lot of support there. Also, the alcohol-related facial features are not associated, as we just talked about, with autism, and growth deficiencies, not necessarily specifically associated with autism. And it's not always associated with FASD. And what we have found in our database at UW is that it's height that tends to be one of the bigger predictors of growth in FASDs. Height and weight are looked at equally, but height has been one that has been standing out. So shorter stature has been more associated with prenatal alcohol exposure in our data set. So that's still an important area to consider for the diagnosis. How am I doing on time?
It's 11:21.
Okay.
So yeah, we could have another.
Okay,
We
good.
give about half an hour. For
Great, good,
questions.
because I still have I have a lot to talk about. Let me tell you quickly about the sample that I did that we did pull from, and this is really exploratory right now. We're just doing some exploratory analysis, looking at 21 people from our sample, and these 21 individuals all have FASD, and I'll talk about the spread of that diagnosis, and either an autism diagnosis or highly suspected autism. And that was 21 people over almost a 2-year period, which is actually quite high. We typically will see 70 people total in a 2-year period, and so 21 was a large amount of our sample. 62% of those 21 were assigned male at birth. That was 13 of them. One of our sample identified as non-binary, but I went with the assigned sex at birth for that percentage. 47% were white, so 10 of them. My internet connection is unstable. Go away. Okay, there it goes. Hopefully I'm not breaking up. 28.6% were multiracial, and that was 6 of them. What's interesting about that is most of them were either indigenous and white or black, and only one of them had more than 2 other racial identities. And we had 14% indigenous and 9.5% identified as black, and that was only 2 of the sample. So again, very small sample, not really representative of our population, but these are the folks that came out in this sample that all have autism or suspected autism. The age range is huge. It was 1 year, 10 months to 18 years, 9 months. Our median age was 9 years. The average age of diagnosis was 8 years, 8 months. The range was 4 years to about 17 years. Our national survey of children's health, as reported on Autism Speaks, the average diagnosis right now in the US is 5 years. A little bit older, a little bit later for girls. There's a difference in diagnosis, some subtle presentations can be missed often with girls, so they might be identified more towards 6 or 7, but the average age was 5. And so at our age is older. I think that talks a little bit more to the complexity of the kids who have both PAE and ASD. Like I mentioned, all of them had prenatal alcohol exposure. Diagnoses ran the gamut of our spectrum, so I'll talk about that in just a second. 12 of them had previous diagnoses of ASD. 8 were suspected ASD, and when I say suspected, is we on our team, and most of us are also in autism diagnostic clinics, but the way our team runs, we just don't have time to do a fully comprehensive diagnosis. We typically get a little bit of time for 3 different disciplines: our speech language pathologists, our occupational therapists, and the psychologist have about 2 hours to really fill in any of the blanks that we aren't able to capture through record review, and really just focus on those categories that are going to help us determine an FASD diagnosis or not, right? So we're not necessarily able to take an hour to do an ADOS and the full, well, we can take a full hour and a half to do developmental interview because the MD is doing a developmental interview while we're doing our testing, but that's not necessarily the purpose of our clinic. So when we say that there were 8 suspected autism, that means it was quite highly suspected, and several of those were younger and had evaluations already scheduled because other people had concerns around autism as well. There was one of those folks that had initial concern for autism, but it was ruled out. But there were still some underlying symptoms. the diagnoses, it's interesting. We tried to pull this sample because we wanted to look at individuals after the pandemic when we were able to start seeing people in person again. There were a few of the diagnoses that actually happened during the pandemic, which is kind of problematic because most of the time when you're trying to do an autism evaluation, you're looking for things like shared affect, you're looking for eye contact, you're looking for facial expressions, all sorts of things that you really can't see when you're wearing a mask, right? Or how are they responding to you as the examiner when you're wearing a mask? That really does change the dynamic of an interaction. So I'm wondering, looking at the data, I'm wondering if that initial concern for autism, but autism was ruled out, might have been sort of an artifact of having an evaluation during the pandemic, whether or not it might be warranted to look at again. So I kept her in the sample because I think it was warranted. Also interesting, 4 of our diagnosed with autism patients also had genetic conditions. I'll share those with you in a second. Just quickly, broadly, cognitive standard score average was an 88.7, where the average range would be 85 to 115. You can see the range here was 60 to 115 in this sample. 5 of the individuals had significant composite discrepancies. We often will look at that too. What we see, especially with prenatal alcohol exposure, is their complexity comes in the variability of their functioning. So we often will see very intact, strengths in one area right next to an area of very significant deficit. And so it makes these individuals oftentimes very hard to parent, very hard to educate, because one minute it seems like maybe they understand or they've got it, or they're functioning as we would expect them to, and then the next moment something is missing, or something is happening that the emotion dysregulation has taken over, or memory challenges have taken over and they've forgotten something, or attention issues have jumped in. And so just the variability in that functioning is hard to navigate as a caregiver. So it adds to the complexity. And so even when you have discrepancies within the cognitive area, so verbal reasoning versus nonverbal reasoning, or verbal reasoning, nonverbal reasoning, spatial reasoning, those types of areas, we're looking at those, and those 5 of them had those significant discrepancies within that one domain. So you can imagine the complexity there. The adaptive standard score mean was 71. 70 is 2 standard deviations below the mean, and the range there was 54 to 85. So you can also see that it's discrepant from many of the cognitive functioning areas. So it's not necessarily that these individuals meet criteria for an intellectual disability as well. Sometimes they do. But the adaptive functioning, even with intact and foundational thinking and reasoning skills, just being able to navigate day to day is impacted by other things. And that's usually the executive functioning. It could be language challenges. It could be motor challenges. Lots of things can factor into what impact the adaptive functioning, but it gives us a sign that this is a population that needs support day to day in their daily living. And again, remember, these are individuals with both autism or highly suspected autism and FASD. So we saw high rates of executive function in this population, and motor delays, mostly fine motor delays. There were all of the patients had clinically significant externalizing and many internalizing behavior problems. I had mixed memory results, so 8 individuals had were at less than the 2nd percentile out of 13 of those that we have memory results for. 8 had documented language delay. Some of those had caught up, had good intervention, and no longer exhibited language delays. And by language, I'm meaning either very significant articulation, expressive or receptive. I'm not talking about social communication in this language delay here. Very high rates of ear infections, often having tube placements, allergies, asthma, sleep disturbances. So all of the things that we were talking about before that the literature is showing is showing up here in this population as well. A difference that I hadn't seen much of in the literature is the trauma history. So 16 of our 20 had pretty significant trauma experiences, including multiple placements, some pretty significant abuse experiences, neglect, loss of caregivers, and sometimes that loss was abandonment, but most often that was the death of a parent. Very long NICU stays, so also medical issues. So quite a heavy trauma history, which we also know impacts brain development. So another thing to think about with our FASD population that's not necessarily as inherent is not the right word, but as common in the autism population. Co-occurring conditions in this group, we had 11 of them had ADHD, so that was 52%. 3 of them had suspected ADHD. They were just too young to diagnose, but I was in those sessions with those little guys, and man, were they busy. So pretty sure that number will pop up to 14. We did see anxiety, so generalized anxiety disorder, separation anxiety, and 1 selective mutism. Mood disorders, so there were depressive disorders, dysregulated mood, dysregulated mood. I never get DMDD right. I don't know why. Help me out here. Dysregulated mood disturbance disorder. No, I don't know. I should write it down every time this happens, I swear. And that's going to be recorded. That's great. I did mention the disruptive mood dysregulation disorder. Thank you, disruptive mood dysregulation disorder. I bet that was popping up in the chat.
It was. Just as you said it.
Thank you, chat people and folks in the room. So trauma, obviously we've got the PTSD adjustment. We do get a lot of reactive attachment disorder diagnoses in this population too, whether that's true or not. Conduct, ODD, intermittent explosive disorder is a new one that's popping up since the new DSM-5. Intellectual disabilities, global developmental delay, language impairments, and specific learning disabilities. We often think of specific learning disabilities as being more prevalent in math with FASD. This group had math and literacy learning disabilities, so, and that was just kind of broad. And I think we see that in general, especially for the kids who have histories of ear infections and language delays. So hold on, I gotta get this guy over here to get moving forward. All right, so ASD specific trends in this population. Every single patient had some sort of social communication challenging, and the main one was difficulty forming, maintaining, or understanding relationships. Again, going back to those criteria for ASD. In the area of repetitive and restricted interests, the insistence on sameness and inflexibility, and sensory processing differences. Every single one of these 21 patients had those areas, so those would be ticked off. All the concerns began before the age of 3, even in those 18-year-olds that we weren't even seeing until adulthood. There were concerns early on, and then differences and deficits were resulting in functional impairment. So very close. The only areas that we would be looking at is to see whether or not there were also difficulties with nonverbal communication and reciprocity. But presumably they exhibited those. We just didn't have hard data on it. The FASD diagnoses in this population, 3 of them had FAS. One of our 2 almost 3-year-olds got sentinel physical findings with both face and growth areas, but had only 1 or 2 areas of neurological dysfunction, so the -2 standard deviations or concerns in any area. So the diagnosis is sentinel physical findings, neurodevelopmental disorder, alcohol exposed. That is, well, actually we probably at that age called it neurodevelopmental delay, but that one more hit if that child got autism diagnosis and ADHD or a learning challenge, for example, that would put that up into the FASD category right away. So most likely that's going to pop up to 4 with full FAS, which is higher than what we typically see. If you remember, our regular population was 9%. So that would put it up to 19%. Even without that child, it's more than what we would expect in a small sample like this. 57% had static encephalopathy, and of those, 28%, or of all of them, 28% had sentinel physical findings. Those sentinel physical findings, though, were only growth, so very few of those would none of them would escalate to FAS because they would never have the facial features because we'd already measured those. However, in the NDAE group, which was 26 or 28.6%, there was the one I had mentioned that has both face and growth, which would likely elevate to FAS if they showed some other developmental delays, which, we don't have a crystal ball. Some good interventions and accommodations can help prevent that, but when you have the face and growth challenges, we typically see that becoming full FAS. And then 2 of those individuals had sentinel physical findings, only growth with NDAE, and I think both of them were young. We're older, so we were able to measure many areas. I think they were 10 and a half, and so I wouldn't expect that diagnosis to change. So there's some stability here, even though there's some variability with our younger individuals. Just quickly, the genetic, this is a very busy slide. I'm sorry, I tried to figure out how to write this in here. I am not a geneticist or that type of scientist at all, so I did my best here. I had to rely on my scientist partner to help me out. But one of the children had Down syndrome, which of course is associated with facial features, which we have to think about, especially if we're looking at facial features that are associated with FAS. And Down syndrome is also associated with cognitive and learning delays. And then there's other medical and physical challenges, and also definitely things that are associated with FAS as well. This individual had full FAS and all 3 facial features associated with FAS with prenatal alcohol exposure, as well as the typical epicanthal folds and other facial features that you would see with Down. So this was more than. This picture right here is, where's my, there we go, is of a child with Noonan syndrome facial features. And so broader forehead here, wider eyes, wider nose, supposedly pretty predominant philtrums supposed to be have, kind of cupid bow lips, pointy chin, low set ears, it's kind of slanted eyes a little bit. That's a typical face of Noonan syndrome. But one of the things that we found with the child who has Noonan syndrome in our sample is they had none of the facial features that were associated with FAS, and ended up with a diagnosis of sentinel physical findings, static encephalopathy. The sentinel physical findings were growth, right? Short stature, that's associated with Noonan. So we can't actually say, is that associated with alcohol or is that Noonan's? It's most likely Noonan's, but that's how our criteria are. And, it really doesn't change the diagnosis much, and it will not change. She doesn't have any of the facial features. So it just helps kind of better explain the added complexity of the prenatal exposure to this genetic syndrome. There are also other genetic differences, variations, I guess I would say. There was this CAMK2B, which is a gene that supports learning and memory. It was associated with microcephaly, again, something that we see in FAS, hypotonia, global developmental delays, seizures, GI, sleep, vision. And also has facial features associated with it too. So other things to really think about. Oh, this is the one with the prominent philtrum. And the pointy chin. So you can see lots of facial features overlap. There's a big call for when we are looking at prenatal alcohol exposure that we really should also be looking at genetic testing and genetic variation so we can really rule in or rule out. However, I think this example of the Noonan syndrome is that we can differentiate the three facial features at the degree that we look at them when with the palpebral fissure being 2 standard deviations below the mean, with the degree of the lip circularity and the smoothness of the philtrum. When we have all of those areas, all 3 of those facial features, it's very specific to alcohol. So you can parcel it out, but we try, we would want to be able to look at those other syndromes too. Am I running out of time?
I'm giving you the time.
Okay, good. I will stop talking about those. So continued areas, as real quick. This is what I was making a call for, continuing to collaborate with our basic science and genetic researchers. There's a lot of really interesting work that can be done here. Thinking about what's the resiliency or the vulnerability that different genetics can cause. I wonder about whether, like I mentioned earlier, prenatal alcohol exposure, is that the environmental agent that might influence the potential genetic predisposition, particularly for autism. I think about things like folate deficiency. We didn't even get to talk about that, but leucovorin is a really big thing right now in autism world, but we know folate deficiencies happen with alcohol exposure. Anyways, my next steps, so like I said, this was a teaser, is to dive more into our database to continue to compare now FASD with and without autism, really look at those developmental profiles and see if we can spot some differences. This is work that's being done at the University of Rochester right now as well with their database, but also thinking about what are those diagnostic changes from the 2013, are we going to see more PDD-NOS before then? I imagine yes, that would be what I would expect. And then also, what's this? Why did we have this influx of people right after the pandemic with kids with ASD coming into our clinic to find out what's going on, especially with prenatal alcohol exposure? Is it an influx? What was going on there? And then social communication disorder. I don't see that being used very often. I wonder if that's under-identified, and that's basically, it's essentially autism without the repetitive behaviors and restricted interests, right? So it could be something that's being overlooked in our population. All right. I just going to say really quickly, this I think it's totally consistent with the information that we have so far. And it confirms what I see from caregivers is that they come and they say it's more than, it's just more than, and fill in the blank, right? It's more than, it's ADHD plus, it's autism plus, and it just really points out to the complexity that prenatal exposure causes in individuals, and in terms of their functioning and their that variability. So I guess I had questions for you all, but we don't have time for them unless you have questions for me that I have time to answer.
We do
Okay.
have questions. Do you want
Should
me
I
to
stop
help
share?
bring up? Oh, yeah, you could stop share. And also want to bring up the Q&A so you can see it yourself too. Here.
Okay.
And so we haven't had a lot of questions specific to FASD and ASD, which was we were hoping to.
Okay.
But we've had a lot of questions around some of the different aspects of FASD, considerations in out-of-home care, also one around trauma, comorbidities between FASD and trauma. So I guess, yeah, if anyone does have any specific FASD, ASD questions, if they'd like to submit them, or anyone in the room, that'd be really great. But otherwise, we can talk about some of the other questions. Some of them were a little bit unclear, maybe comments more than questions.
Yeah.
But there might be one that you would like to answer.
I'm trying to read them as quickly as I can.
But otherwise, I can suggest one for you.
Okay, go ahead. Suggest one while I skim through.
Yeah, so R. Fuller has said, if FASD appears present facially and in growth stature, but not cognitively or behaviorally, is there any reason to get FASD diagnosed if it's not contributing to difficulty or struggle in life?
This is going to be a complete opinion of mine, and I believe that this is true. If there's no functional impairment, I don't believe we need the diagnosis. The diagnosis is meant to inform interventions and accommodations, and if there's no need for interventions and accommodations, then there's really no need for a diagnosis. If it's, yeah, I think of it as a means of opening a door to access to services oftentimes. And if you don't need the services, then it's not necessary, unless it's somehow a way of helping you better understand yourself, I suppose. I would just wonder about what the reasoning behind the wanting to know is. But if there's no functional impairment, you're probably just going to get kind of null results. Right?
But what if the person is an adult?
Yeah.
And maybe they didn't present earlier on, or were picked up. Because we know that has to happen in early childhood, not before 3, there has to be some delays. So
Yeah.
you would suspect that, no, that wouldn't be the case, but there are, you know, people who have missed out on some of that screening and some of the services. Yeah, but obviously being functional enough within their own communities.
Yeah.
Yeah, so.
From that perspective, then
Oh,
the better
I'll just-
understanding of yourself, I think,
Yes,
would be.
yeah.
I'll just repeat that question.
Oh, thank
because
you.
Apparently they're not here in the room. So it was really a question around what if, well, you might be able to repeat it better than me, but if
Right.
it's, if the person comes to the table for diagnosis in adulthood and some of those early considerations are missed.
Yeah, well, and I often have heard from adults who are quite functional as adults, but talk about how they struggled as a youth, but had to figure it out on their own, and they came up with their own accommodations, and so then getting a diagnosis later in life, even if it doesn't necessarily, they don't necessarily need supports and accommodations, can help them understand themselves and kind of figure out why did they struggle and what was that about for them. I think that could be a valuable reason for just self-identity purposes.
And yeah, I guess there was a question around somebody talking about their experience of diagnosing in their clinic, and someone in their team had twins, and one got an FASD diagnosis and the other twin did not. And if you could explain a little bit about that.
Oh, that is it. So we have a paper out actually on all the twins that came from our the years that we have been seeing patients, and so I'd be curious. I guess my guess would be that they were fraternal twins, because in our findings was the identical twins ended up with identical diagnoses, whereas fraternal twins ended up looking more like, almost like siblings. They didn't necessarily get the same diagnosis. And the conclusion from that paper was really thinking about the resiliency and the vulnerability of each individual child, each individual fetus, and what could go into that, because they do have different genetics when they're fraternal, right? Different makeup and also potentially different exposures. You'd think they'd have the exact same exposure, kind of depends on the placenta and things like that and how that's all arranged. But I think the big conclusion that we took from that paper was, having the genetics very similar and having the same diagnoses, whereas when genetics change, diagnoses could differ wildly, was that told us that it may not be as worthwhile to try and figure out thresholds or timing or dosage, because you can't necessarily figure out the vulnerability of your child, right? And so at that point, you'd be thinking that just no alcohol exposure is going to be the best bet. And that's the message that I think we took from that paper, is regardless of what people think about dosage and timing, it's about the individual baby and their vulnerability or resilience. And we just don't know. I don't know, maybe one of the days we'll have an extra test for that vulnerability, but we don't know what that is yet.
Yeah. another question that's popped up is, how often does it seem that autism and FASD diagnosis are actually because of misdiagnosis of autism before correct diagnosis of FASD, in brackets, but versus actually having both conditions?
Oh, that's interesting too. Okay, this is I'm talking in hypotheses right now. So my hypothesis is that particularly since the change in the diagnosis in 2013, I think that there's more individuals who would not have met criteria for autistic disorder when it was autistic disorder, but would have met criteria for PDD-NOS in the DSM-4 criteria. Now they're meeting criteria for full autism spectrum disorder. And then the question is, is that truly autism, or is that just another way to capture what we're seeing with prenatal alcohol exposure, or another kind of neurodevelopmental diversity? I was always trained that some of the core features of autism are the social communication and the repetitive behaviors, restricted interest. So it's hard for me to kind of change my perspective. It's a paradigm shift for me that I still am having carryover, that I think of autism as having those RRBs, if you will, rather than just the rigid, I'd say just because they're pretty impactful, the rigidity and the sensory processing differences. And so that's what I think we have maybe an increase in that, because a lot of kids with FASD have the rigidity and the sensory processing differences, and maybe not those, what I would have considered more core autism symptoms in the past. So that's a hypothesis I have. I want to explore that.
I'm curious as well, just about as a non-clinician, but you have single care versus multidisciplinary team, maybe the challenges of the complexities of both. Being diagnosed by a single person might be challenging. I'm just wondering if you talk about that. So you're different teams.
Yeah, so the question in the room was about the complexity of, or maybe if I could summarize, maybe pros and cons of the two different approaches, whether you're doing like a lead diagnosis, a lead practitioner diagnosis, so a single discipline diagnosis versus a interdisciplinary team diagnosis. And I think the way we do it, there are definitely pros and cons to both. Navigating both systems can be challenging at sometimes, when I really am at one clinic and want to have facial features and growth, because DSM diagnosis will miss full FAS because we don't do facial features or growth typically. At Children's, what we've done is we've come up with a workaround where we're doing some screenings, and then we're referring to the interdisciplinary team if we feel like that's warranted, so that we're not missing full FAS, or a diagnosis of FASD that would be important for that individual, because maybe we don't have the thresholds. I think that's one of the challenges is so many of our population are in out-of-home placements. We might not have that information about the drinking, the dosage, the timing of drinking during pregnancy, so we aren't able to really capture that with many kids. Whereas that's not a criteria for the UW clinic, the interdisciplinary clinic, the medical clinic, because we are looking at those medical aspects. One of the things that's really nice about being able to do the single discipline diagnosis is that we have more time with a family. We have constructed it as a therapeutic evaluation, so we're able to do some really in-depth diagnostic interviewing, some really comprehensive testing over time. And then we're also able to take a couple extra times to do feedback with the family, where we can actually plot out on a grid the child's strengths and vulnerabilities, so that the caregiver can see those peaks and valleys to help them reframe that complexity of their child, and reframe the behaviors that they're seeing, and better understand it then as brain-based challenges. So that's a really large benefit for a lot of families. And then we take a second day to talk then about, okay, what do we do? What are the recommendations that we have? So we spend an entire session just helping a family reframe and really understand their child as a whole based on the data that we got. So pros and cons to both, right? Yeah,
Do we have time for one more question?
I think so.
Uh,
I have 4 minutes, right?
All right, so I've had one just come in. When ASD and FASD co-occur, how have you seen the dual diagnosis contribute to helpful strategies, supports, and self-identity? Nice big one.
That is a big one to end on. All right. Thank you, Monica. How have I seen them contribute? Again, I think it's just really better understanding the plus, that this feels more than, especially to a caregiver or an educator or someone, a provider for the individual. In the US, and I don't know if this is similar here, but in the US, autism diagnoses tend to get more services and more recognition than FASD still do.
Okay, so
We're still working on, making sure that that's understood. Excuse me, some of the members of our team had lobbied with our state, Washington State, so that FASD was considered a diagnosis under their Developmental Disabilities Administration, so qualified for state services. Not all states have that, so it takes, a bunch of people to fight for those rights, and that's exactly what ASD did. FASD is a bit younger than ASD in terms of recognition, so I think we'll get there. So with the co-occurrence, I think it potentially opens some extra doors to supports. A lot of the supports they need are very similar, right? Around social communication, social interaction, self-regulation, sensory processing, those things that were all overlapping. So they could get, a single approach, not necessarily a single approach, but an approach that you would have worked with for either diagnosis will be beneficial to both of those diagnoses. But then it would also help you think about, okay, what is also different? And is this behavior communicating to me a can't versus a won't, right? And how do I frame that? So I think it can also help caregivers better understand their children. In terms of self-identity, I think, we have self-advocates on both sides. We have the change makers for FASD. We have autistic self-advocates and people who band together and support one another. And so there's communities out there that I think are really important to get connected into if you're an individual with either of these diagnoses. So I think that can also help build your understanding. And then I just put a plug out there, if you ever have an opportunity to come to the international conference that I had been mentioning, every other year, it's focused on adolescents and adults, and there's a whole track for adolescents and adults to do some of that self-exploration in a supported way with other individuals with FASD anyways. I'm not sure if we have a similar thing in the ASD diagnostic or ASD conferences like INSAR and things like that, but they should. I've heard it's very powerful. Yeah.
Well, I think that takes us to the end. So thank you so much for being with us and this really super interesting talk. I think we're just scratching the surface and could go on and on. And the questions are still rolling in, and really great ones too. So Prue's tried to address some that she was able to address, because we're really sorry we weren't able to get to everyone.
Great. Thank you, Prue.
Yeah.
And please feel free to reach out to us. We are open to collaborating. We'd love to work with folks who are interested in these areas. And you can always come and visit our training clinic. We can Zoom you in. You can come in person. It's completely free training if that's of interest to you. So reach out to us at the UW FASDPN.
It's great. And I'll let everyone know we've recorded this webinar. So we'll be sending that out through our mailing list and everyone who's registered. And if you haven't already, we will put our mailing list in the chat, so you can sign up to that. It's a great way to keep up to date with our webinars that we're going to continue to do over the next couple of years, and other resources that we're creating. And also we'll put in a link to our website where you can access previous recordings with the UQ Australian FASD Guidelines website. And I also want to mention that if you want to keep learning on this topic, the FASD Hub does have a webinar coming up next year in April on FASD and autism and ADHD with Raja, hope I do her name justice, Mukherjee, who is a FASD experienced psychiatrist in the UK. So please check that out on their website. And yeah, thank you so much for joining. Thanks again, Erin.
Yeah, thank you for having me. Thanks, everybody.